Greetings, everyone. I'm Rich Auchus. I'm a professor at the University of Michigan, and I am happy to be here today to discuss some research highlights for Cushing disease and Cushing syndrome for 2022. These are my disclosures. So I think you're all aware that Cushing disease is a rare endocrine disorder characterized by chronic hypercortisolism. Now, Cushing syndrome means any form of endogenous hypercortisolism. Cushing disease refers to Cushing syndrome when it's caused by an ACTH-producing pituitary adenoma. Now, this is a rare condition, and so data that's presented, for example, at the Endocrine Society meeting can get lost in all the other information and materials that is simultaneously being presented. So today we're going to kind of pick out those highlights that occurred during the year and at these meetings and try to review them. So just to get everybody oriented, symptoms include weight gain, particularly in the face, in the head and neck area, central obesity with thinning of the arms and legs, skin thinning, hirsutism, amenorrhea, and balding, muscle weakness and muscle atrophy, which accentuates the loss of tissue in the arms and legs, hypertension, poor wound healing and risk of infections, and development of glucose intolerance and diabetes mellitus. Treatment options. Now there are several. They include neuromodulators of ACTH release, such as pasireotide and cabergoline. There are several adrenal steroidogenesis inhibitors, ketoconazole and levoketoconazole, mitotane, etomidate, and osilodrostat. There is a glucocorticoid receptor antagonist, mifepristone, and people can use one or in combination. Now, I'm going to break this talk down to the first part, which is about diagnosis, morbidities, and biomarkers, and then the second part will be about treatment. So this study looked at a series of patients with Cushing's disease and others who had non-functioning pituitary adenomas that were still positive for ACTH on immunohistochemistry. And what they wanted to ask is the question of, is it weight or is it weight trajectory that is a better predictor of Cushing disease? There have been several studies recently where weight gain in and of itself was actually a negative predictive factor for whether people have Cushing disease. So in this group, which was predominantly female, the BMIs were not that high. These are sort of typical American BMIs. And the weight gain was not that much, but it was something. And so the question is, what percent of people had gained weight 2 kilograms or more over the 6 months prior to the evaluation? And so the people with Cushing's disease, a much higher proportion of them had gained those 2 or 3 kilograms in the last 6 months rather than the people with the non-functioning tumors. So the author suggested that rather than looking at BMI itself, that we should look at recent changes. I think this is a good clinical pearl because we are looking for recent changes rather than prior history in guiding us to whether or not our pretest probability is high for Cushing disease or not. So I like this study, although again, a small study with a limited bit of information, but useful. Now, this study from Mayo Clinic looked at bone health in people with adrenal disorders, and they focused on ACTH-independent cortisol excess. And they broke their patient groups down into people that had either non-functioning adenomas, mild adrenal cortical syndrome, which is MACS, M-A-C-S, people with primary aldosteronism, people with primary aldosteronism plus hypercortisolemia, and people with overt Cushing syndrome. And overt Cushing syndrome, we usually use a dexamethasone suppressed cortisol of 5 as a cut point for that. It's a useful ballpark number. It's unlikely to be a false positive when it's over 5. And if people have a smoking gun, being an adrenal adenoma, particularly if it's over 3 centimeters, is very suggestive of ACTH and independent cortisol excess. So not surprisingly, they found that the people with overt Cushing syndrome had lower bone density and greater degree of osteopenia than the patients who had non-functioning tumors. When they compared the max patients who had these intermediate dexamethasone suppression tests between 1.8 and 5, there wasn't necessarily a worsening degree of bone loss compared to the non-functioning adenomas. But when they used the dex-suppressed cortisol as a continuous variable, which is another way to analyze the data, they did see somewhat of a graded increased risk of low bone density as they went to higher degrees of autonomous cortisol production. So again, I think the study confirmed something that we knew before about people with overt Cushing syndrome, provided some information about using cortisol as a continuous variable, that there is a graded effect. But again, a small study that will need to be replicated. But I think it's an interesting piece of information that needs to be studied further. Now, this is from Johns Hopkins, where they looked at inferior petrosal sinus for predicting tumor lateralization. Now, here, I'm not talking about distinguishing pituitary Cushing disease from the ectopic ACTH syndrome. We all know that inferior petrosal sinus sampling is the best test for that. What this study was looking at was whether it could tell you whether the tumor was on the right side or the left side. And this is a constant quandary that we face based on limited information. So they had 27 patients who had petrosal sinus sampling. And in 21 out of 22 patients, where the MRI and the lateralization, the right to left localization of the petrosal sinus sampling was concordant, there was concordance also at surgery. Now, of the 5 patients who had discordance between the MRI and the petrosal sinus sampling results, where the petrosal sinus sampling suggested the tumor was on the left side, but the MRI showed a tumor on the right side, the MRI was right 3 times out of 5. And in the other 2 cases, the tumor was actually bilaterally or centrally located. So the point that the authors make, which I think has been made before, is that while petrosal sinus sampling is definitely the best test we have for excluding the ectopic ACTH syndrome, it can't really tell you what side of the pituitary the tumor is located. And MRI is as good as we've got for that purpose. So if the petrosal sinus sampling points to the pituitary, and there's an adenoma located on MRI in the pituitary, most of the time it's going to be that adenoma that's the causative tumor, even if it's less than 6 millimeters. So again, this is a modest size study. 27 patients with Cushing's is a fair number of Cushing's patients. But I think this is something that we should not place too much weight on the lateralization of the petrosal sinus sampling. And then the last study I want to review in this part of the talk is about what androgens are responsible for hyperandrogenemia in Cushing disease. So we all know that the adrenal makes androgens. We think of DHEA sulfate, we think of androstenedione. Some of that androstenedione gets metabolized onto testosterone in peripheral tissues. And we know that women show signs of androgen excess when they have Cushing's. Men usually don't because of the gonadal component. But the question is it the testosterone that's coming from the adrenal that's really the main source of androgen excess? Now, the adrenal also makes 11-hydroxylated androgens. In particular, 11-hydroxyandrostenedione is a major product of the adrenal glands. And that gets metabolized in peripheral tissues to 11-ketotestosterone. And 11-ketotestosterone is a bona fide androgen. It's actually the major androgen in fish, in the bony fishes or teleost fishes. So we've known about this for years, and it's been a little bit ignored. So Adina Turku and our group here at Michigan and various other groups around the country and around the world have looked at this. And this is a study from Germany where they looked at these 11-oxygenated androgens in saliva from patients with Cushing disease. And what they found is that in treatment-naive women with Cushing's disease, they had quite elevated salivary 11-hydroxyandrostenedione and 11-ketotestosterone throughout the day compared to controls, whereas actually their androstenedione, testosterone, and DHEA sulfate were pretty comparable to controls. And of course, you also have to look at SHBG because a lot of these people also have low SHBG because of their insulin resistance. So, and then they took people who were treated with 11-hydroxylase inhibitors, specifically osilodrostat and metirapone, and they found that, not surprisingly, it lowered these 11-oxygenated androgens. So, and so I think the point about this is that for many years we've been not measuring all the androgens that are relevant in Cushing's disease, and these 11-oxygenated androgens are a major component, and reducing these is probably going to be the way that people are going to improve from a perspective of hirsutism and androgen excess. So I think this is something we're going to need to pay more attention to in the future. Now, this is commercially available in a small number of referral labs, but as it picks up, I think that as more information accumulates, these will become more available to the practicing physician. Okay. So now I want to shift gears and talk about clinical trials. So the majority of the data that has appeared has been about osilodrostat, which used to be called LCI 699. It's an orally active inhibitor of 11-hydroxylase, which is the enzyme that catalyzes the final step in cortisol biosynthesis and therefore decreases cortisol production. Now, of course, just like in 11-hydroxylase deficiency, putting an enzyme inhibitor there is going to increase adrenal precursors proximal to the block. And there have been two large phase 3 studies, LINK-3 and LINK-4, where LINK-3 was a randomized withdrawal study in the middle of the trial. LINK-4 was randomized up front, and these data have been published, and they've also been presented at the Endocrine Society meetings. So starting with what's new is the LINK-3 long-term results. So long-term evaluation of control and of adverse events from the LINK-3 trial. So what did they find? So adrenal hormone precursor accumulation occurred in over half the patients. It was managed with additional therapy in most of those patients, and it only required discontinuation in 2 out of 137 patients. So again, we expect this to happen. It's usually managed with other medications such as spironolactone, but it rarely leads to discontinuation. And those adverse events are mainly hypertension, peripheral edema, and hypokalemia. So just as in 11-hydroxylase deficiency, the buildup of the precursors includes deoxycorticosterone, which is a mineralocorticoid, which can lead to hypertension and hypokalemia. Interestingly, though, DHEA sulfate, which you tend to think of accumulating in androgen excess states, did not increase during treatment. We're not sure why that is. And hirsutism generally improved or stabilized. And this may be related to the reduction in those 11-oxygenated androgens that the German group found. In males, testosterone levels initially increased and then stabilized. In females, they initially increased and then they decreased almost to baseline. But again, that's only one component of the androgens in these people. So over time, the androgens tended to come back to where they were before. Comorbidities. If the question here was to determine if the cardiovascular and metabolic related physical features and quality of life were related more to the mean urinary free cortisol or to the late night saliva cortisol or to both. Now, the primary endpoint of the trial was urinary free cortisol, but late night saliva cortisol was also measured. And so looking at people who had just their mean urinary, if they had both the mean urinary free cortisol and the late night saliva cortisol controlled, their blood pressure, their fasting glucose, and their hemoglobin A1C seemed to be optimal. A little bit better than people who had just the late night saliva cortisol or just the mean urinary free cortisol combined, and certainly better if neither was controlled. So it would suggest that as we're starting to learn how to use some of these new medications, that our goal should not just be control of urinary free cortisol, but also of the circadian rhythm. And so this is something that I think people are going to be paying much more attention to in the future. Okay, now, now the Link 4 study was the follow-on study where there was a 12-week randomized double-blind placebo-controlled period in the beginning. And then after the randomized withdrawal period, there was 32 weeks of open label osilodrostat where patients were all crossed over. And then an optional extension phase that continued on in people who were felt to be benefiting from the trial. So one thing that you look for is how many people wanted to go in the extension phase. And of the 65 patients, 60 of them entered the extension phase. Cardiovascular, metabolic related parameters, physical features of hypercortisolemia, and Cushing's quality of life score were measured at baseline and every 2, 4, 12, or 24 weeks and at end of termination. So there were several abstracts and a recently published paper. This is from the paper in the Journal of Clinical Endocrinology and Metabolism. So these are the patients who were treated with osilodrostat. These were the people who were on placebo. And you can see the drops in urinary, these are waterfall plots as we call them. You see the drops in urinary free cortisol in the group that was taking osilodrostat. The people who were on placebo largely didn't change at all, even if they were very close to normal. Only about 7% of people normalized in the placebo arm, whereas over 85% in the osilodrostat arm. And with the information that we learned from Link 3 and Link 4, we were able to get people to goal pretty quickly. But this was a forced up titration over that 12-week period. And so again, to convert these graphs into mean data here on the right, the people who are on placebo, not much change in urinary free cortisol, nice reductions in the people who were on osilodrostat. Interestingly, they didn't quite rebound back to baseline when the drug was stopped. And then as people were crossed over, then both groups were nicely controlled as the study went forward. Looking at cardiovascular risk factors and quality of life, the mean osilodrostat exposure from core baseline to study end was 87 weeks. Average dose was 4.6 milligrams a day. So in the vast majority of people, the physical features improved or remained stable from the core baseline to the end of treatment study. And most of the cardiovascular metabolic parameters also continued to improve during long term. So for example, these are blood pressure measurements, fasting glucose, which wasn't that bad to begin with. So we didn't expect much of a change. And certainly weight and waist circumference improved and continued to improve over the trial. So I think this is probably the best parameter that we have, the weight and the waist circumference, because those were pretty abnormal. And the Cushing's quality of life scores also improved. Now, if you look at specific features such as ecchymosis, striae, hirsutism, muscle weakness, facial rubor, central obesity, fat pads, there was improvement in somewhere between 20 and 65% and stabilization in most of the other people. Very few people had regression with control of the urinary free cortisol. And then as we went forward during the extension phase from baseline to week 48 to week 72 to the end of treatment, the percent of patients with normalization of the urinary free cortisol stayed around around 70%. Of course, there were some fewer people as you went further down, but somewhere between 60 and 70%. The median and the mean were somewhere between 0.5 and 1.2 times the upper limit of normal. And ACTH rose slightly during the trial from about the upper limit of normal to about 3 times the upper limit of normal. Adverse events, as you look at this list, decreased appetite, arthralgias, fatigue, nausea. These are all glucocorticoid withdrawal symptoms. So it's not clear if these are truly adverse events or simply a reflection of the treatment correcting the hypercortisolemia. And headache and dizziness are sort of a little more ambiguous. Hypocortisolemia related adverse events in about a quarter of the people. And this can be either withdrawal symptoms or true adrenal insufficiency related symptoms. And as I mentioned before, adrenal hormone precursor accumulation related AEs in over half the patients. Hirsutism and acne actually, only occurred in one patient that didn't have it at baseline. So again, generally these improve or stabilize, generally not seeing any worse. And what about tumor size? The median change of pituitary tumor volume from baseline to last available measurement was 4 cubic millimeters, not that large. 2 patients did have to discontinue because of tumor enlargement during the core study, but none in the extension phase. So this is probably more related to the intrinsic biology of the tumor since the numbers are so low. This is similar to what was seen in the pegvisomant studies for acromegaly. And no trend was observed between tumor volume and osilodrostat dose. So again, once people have been on it for a while, we see fewer adverse events, and people who are tolerating it for a modest period of time tend to continue to tolerate it for much longer periods of time. So that's from the clinical trials. Now, this next study, Illustrate, was designed to see how people are using osilodrostat in the real world. So this was a retrospective chart review that analyzed people with confirmed endogenous Cushing syndrome who were initiated on osilodrostat over about an 18-month period from May 2020 to October 2021. So there were 42 adult patients with endogenous Cushing syndrome that were included in this study. So the aim was to present osilodrostat dosing and titration information in the real-world cohort, and part 1 focused on Cushing disease. So the Cushing disease patients, which were the majority of them, about a third of them were started on a dose lower than 4 milligrams a day. So 2 milligrams BID is the typical starting dose, but a full third of patients were started on a dose lower than that. And of those 16 patients initiated at 4 milligrams a day, a quarter of them required dose interruption or down titration, but yet 5 remained on the initial dose throughout the observation period. So again, this study attests to the potency of the drug, the need for starting with a tolerable dose, oftentimes now being lower than the typical starting dose, and titrated slowly. So here's how it breaks down. So again, 62% of patients started on 2 milligrams twice a day, 27% on 1 milligram twice a day, but a few people on once daily. Okay, and patients with multiple encounters, there was again some of this dose interruption when they were started at the higher dose, and actually even the people that were started on the lower dose, some of them required dose interruption or experienced symptoms related to decreased cortisol. So again, emphasizes the need to be very careful in choosing your starting dose and to titrating very slowly. Now, the second part of the study looked at people who had non-pituitary Cushing syndrome, and those were 8 patients. There was 1 patient with ectopic ACTH syndrome who developed adrenal insufficiency symptoms on treatment. 2 of the 5 adrenal Cushing syndrome had symptoms suggestive of glucocorticoid withdrawal, 1 requiring an interruption in therapy, and neither had documented adrenal insufficiency. So all 8 Cushing syndrome patients were initiated on less than 2 milligrams twice a day. with 3 of them remaining on their original dose. So some of these people might have had very mild ACTH-independent Cushing's. Some of the ectopic Cushing syndrome patients had very, very severe disease. So the starting dose was 1 to 4 milligrams a day in people with adrenal Cushing syndrome. About 2 of them remained on the starting dose. 2 of them increased their dose. And then in the ectopic syndrome, there were 3 patients. The starting dose was 2 milligrams twice a day, unchanged in 1, up titrated in 2. So when you look at the urinary free cortisol reductions, there were some pretty profound reductions. One patient had a urinary free cortisol of 57 times the upper limit of normal, and another with 75 times the upper limit of normal. And the reductions were quite substantial in these patients, despite the very, very apparently modest dosing. So I think, again, what these trials are showing us is that endocrinologists are starting with quite low doses, quite cognizant of the potential for causing withdrawal symptoms and adrenal insufficiency, taking their time and titrating the dose. But even these very modest doses seem to be quite effective in patients with quite severe Cushing syndrome, much more than you might predict. And then shifting gears once more, one other trial, the Abacus trial, where instead of osilodrostat, the CYP17A1 enzyme, the 17-hydroxylase 1720 lyase enzyme, the drug abiraterone acetate was used to target that enzyme. Now, it's also on the pathway to cortisol. And this was a phase 2 study to assess the activity of abiraterone acetate to control cortisol excess in people with advanced adrenocortical carcinoma and overt Cushing syndrome. Now, this drug will also lower androgens. It's used to treat prostate cancer because CYP17A1 is on the pathway to androgens. So a lot of these people also have androgen excess symptoms. So it's somewhat plausible to try to treat both of them with this drug. And what you see is that there was pretty amazing reductions in urinary free cortisol with abiraterone, going from a median of almost 400 micrograms per day to about 25% of the baseline levels, and improvements in the Cushing syndrome score in these patients. There were 17 patients. When we use this to treat prostate cancer, we're aware that the cortisol pathway gets rerouted to corticosterone, which is also a glucocorticoid, but less potent, a bit less potent than cortisol. So that was not measured in this study. And it would be interesting to know what the long-term benefit in terms of the Cushing syndrome-related morbidities, glucose intolerance, and so on are with this treatment. It's an interesting thing to think about combining this with inhibitors of other enzymes in the pathway that you might be able to lessen some of the adverse events with combination therapy. So my last slide, the clinical PERS Cushing syndrome is a rare endocrine disorder characterized by chronic hypercortisolism. Cushing's disease is Cushing's syndrome due to an ACTH-producing pituitary adenoma. There may be value in using weight trajectories rather than absolute BMI as a clinical variable when assessing the pretest probability of Cushing disease. I didn't go over the DDAVP stimulation test, but people are using this. IPSS has limited utility in lateralizing the tumor in Cushing's disease when being done to rule out the ectopic ACTH syndrome. The 11 oxygenated C19 steroids may be primarily responsible for the hyperandrogenemia and Cushing disease, particularly in women. Overall, the prevalence of osteopenia and osteoporosis appears to increase proportionally to the increase in the post-dexamethasone cortisol concentration. Abiraterone may be proved valuable in the treatment of Cushing syndrome and particularly in advanced adrenocortical carcinoma. And new data on recently approved therapies demonstrate the safety, efficacy, and durability with improvement of comorbidities, clinical features, and cardiovascular factors. So with that, I thank you for your attention. I'm going to close this discussion.